So when treating neck and back problems, one of the most common things we recommend as far as conservative management goes is trying some injection therapy. And I think patients oftentimes have many questions about what injection did I have done? Or they'll see me in the office and I'll ask them, well, what did the pain management doctor do to you? And they have really no clue understanding what was done or what the injection was. So I'm going to take some time and go over each of these injections and try to explain what the procedure is for each one. So we're going to start down here with the sacroiliac joint. The sacroiliac joint is a glide joint between the iliac wing and the sacrum, and it has a little bit of motion back and forth. Women more than men have problems with their SI joint, and sometimes we'll recommend an injection. We use an X-ray to carefully angle into the joint, and after applying some numbing medicine on the skin, we'll guide a needle into the joint itself. We'll inject some numbing medicine and cortisone and see if that gives any pain relief for the patient. Numbing medicine will give relief right away. So if most of the pain is relieved immediately after the injection, it helps confirm that that's most likely the pain source. The steroid kicks in a few days later and will hopefully give some longer lasting relief and calm inflammation in that joint down. Another common injection that we'll do is something called facet joint injections. And what a facet joint is, it's the joint in the back part of the spine. It's a synovial joint that moves. And if you look right here, you'll see one of the joints. It's connected from the vertebra below and the vertebra above. Using an X-ray guide, we'll guide a needle into the joint and inject the joint. Sometimes, instead of doing a facet joint injection, a pain management physician may do what's called a medial branch block. Big old fancy word. All it means is they're going to block the nerve that supplies that joint. That nerve comes right around the corner, and they'll put some numbing medicine where that nerve goes. If that block takes away that pain, a lot of times the pain management physician will go ahead and bring a heat probe in on another visit, and they'll burn that nerve that supplies both the joint and also dyes and innervates the disc itself. Usually they'll do 2 or 3 because each nerve will supply a joint above or below. The most common injection that's done on somebody's spine is called a lumbar epidural steroid injection. So an ESI, epidural steroid injection, basically means the doctor will be injecting some numbing medicine and some steroid or cortisone into the spine. We usually don't use cortisone. We use medications like triamcinolone, dexamethasone. Any type of steroid can be injected. And the way a translaminar injection is performed, it goes between the lamina, and that's a down the middle injection. It's also the same way they do an epidural when you have a baby. So they'll carefully guide a needle slowly into the spine, and just when they get into the spinal canal, there'll be a loss of resistance to the pressure they're putting through either fluid or dye through the needle, and that will help confirm the epidural location. And then they'll inject the medicine, which will go up and down a couple of different levels. One of the risk factors for this injection is they can inadvertently puncture the sac that holds the spinal fluid, and you can get a spinal headache. That happens maybe 1 or 2% of the time. And it can be solved by coming in and injecting some blood into that space to seal off that leak if the headache persists. Another injection that's performed is called a transforaminal lumbar epidural injection. And what that is the needle is going to come off to the side and into the foramen where that nerve is exiting. Usually this injection is most commonly used when there's concern about a particular pinched nerve, and the goal is to calm the inflammation down around the nerve. The biggest downside to the transforaminal injection is anytime you're guiding the needle in, there's a slight chance you could actually hit or irritate that nerve. And that's why we use dye and X-ray guidance to make sure we stay away from the exit point of that nerve. And then we can also do injections up into the thoracic spine, what's called a transforaminal injection, a translaminar epidural injection, same as we did in the lumbar spine, and same in the cervical spine, coming in directly through the center. Obviously in the cervical spine there's a lot more risk involved because the spinal cord itself is there and the spinal canal is not as wide as it is in the lumbar spine. So these have to be done very carefully, X-ray guidance, and we use dye to confirm the correct location. Some pain management physicians will also do a different type of injection through the front of the spine, and they will actually come in and try to block through the front of the spine where the nerve exits. That's a little bit more of a technically demanding injection, higher risk for irritation of both the blood supply going up to the brain and also for the exiting nerve. Generally, it's less commonly performed. So I think this gives a basic explanation of the different type of injections, basic risk factors for this, and our rationale for for doing the injections.